When you think of serious liver disease like cirrhosis, your mind probably jumps straight to a high risk of bleeding, right? It's a common assumption, rooted in a lot of what we're taught. But what if we told you the reality is far more complex? Like a precarious balancing act where, surprisingly, clotting can be just as big a concern. Okay, let's unpack this. Sounds completely counterintuitive, doesn't it? We're often told that liver disease equals a higher risk of bleeding. But the latest research, well, it paints a much more nuanced picture. Our mission today is to take a deep dive into this really intricate world of blood clotting and bleeding in patients with cirrhosis. We're going to uncover why traditional methods for assessing coagulation, like the INR, fall dramatically short, and explore the alternative, safer treatment options that are now emerging. We'll be pulling insights from recent, pretty cutting-edge studies on anticoagulation and cirrhosis and this delicate hemostatic balance.
It's absolutely fascinating. What's truly remarkable here is how the body attempts to rebalance itself, even in significant disease states like cirrhosis. But this balance, as the studies really reveal, is often incredibly precarious and, highly sensitive to other factors.
Like what sort of factors?
Things like a patient's fluid status, systemic infections, even how well their kidneys are working. It all plays a role.
Right. So let's really dig into this precarious balance. For those of us trying to understand it, what's the fundamental biological shift happening in cirrhosis that, well, scrambles the whole coagulation system?
Yeah, so the information we've gathered shows us a really complex interplay. On one hand, yes, absolutely, there are definite factors that increase a patient's bleed risk. First, you've got decreased coagulation factor production.
Yep.
Think of the liver as like a factory producing most of the crucial clotting factors, those essential proteins that make your blood thicken and form a clot. In cirrhosis, this factory slows down dramatically, which leads to a prolonged PTT or prothrombin time.
Right, that's the lab test showing your blood takes longer than normal to clot.
Exactly. Second, there's thrombocytopenia.
Which just means lower platelet.
Lower platelet counts, yeah. Platelets are those tiny cell fragments that rush to the scene of an injury to plug the hole. Their numbers can drop because, well, decreased production in the liver or increased sequestration, meaning they get trapped in an enlarged spleen.
Got it.
And third, increased fibrinolysis. This is basically your body's natural clot-busting system going into overdrive.
So
the liver normally clears out these clot busters like tissue plasminogen activator, TPA, but in cirrhosis, they build up.
So they stick around and break down clots too quickly.
Essentially, yes. Breaking down clots much faster than they should.
Okay, that all sounds like a recipe for constant bleeding, and it's definitely what most of us would expect. But here's the surprising twist the sources reveal, something that truly challenges that conventional wisdom.
Exactly, because counteracting these bleeding tendencies are several procoagulant changes factors that actually promote clotting. It's wild.
Like,
for one, there's decreased production of the body's natural anticoagulants protein, CNS, antithrombin III.
Those are the brakes on clotting, right?
Pretty much. They're the body's brakes, and when they're reduced, it's like taking your foot off the brake pedal. Clotting can happen more easily. Then you have the accumulation of prothrombotic factors. This includes an increase in things like von Willebrand factor, VWF, and factor VIII.
Okay, so more sticky stuff in the blood.
You could put it that way. They help blood clot. And when factor VIII is high, especially combined with low protein C, it creates what doctors call a hypercoagulable state.
Meaning the blood is just primed to clot too easily.
Precisely. And finally, some studies note a higher incidence of antiphospholipid antibodies in some cirrhotic patients.
And that's another known risk factor for thrombosis, for clotting.
Correct.
So it's not just one direction at all. It's like this biological tug-of-war happening. And the sources even dispel a common medical myth, right? About being auto-anticoagulated.
Yes, and this raises a really important question that many in the medical field have pondered. Is cirrhosis an auto-anticoagulated state? Are patients naturally protected from clotting? The answer unequivocally from the research is no, absolutely not.
Really? So that idea is just wrong?
Pretty much. While these changes might balance out in compensated cirrhosis, the unpredictability in advanced disease is huge. And the documented incidence of VTE, venous thromboembolism, it's about 0.5% during inpatient stays. That proves patients are absolutely not completely protected from clotting.
Wow, that's a critical moment, like you said, for anyone dealing with liver disease.
Mm.
Okay, so given this incredibly complex picture, how do we even begin to monitor these patients properly? What the latest research reveals is some major cracks in our traditional testing, particularly with the INR. Why is INR so problematic and even unfounded here?
Well, if we connect this to the bigger picture, the INR, I mean, despite its really entrenched position in how we're taught medicine, it's highly misleading in cirrhosis.
That sounds serious.
It is. Imagine that critical number doctors often rely on. It's not just flawed. It could be actively misleading, potentially telling a dangerous lie about bleed risk.
Okay, break that down. What does INR actually measure, and crucially, what doesn't it measure?
Right. So it's basically a mathematical manipulation of the prothrombin time. It's designed primarily to measure those procoagulant factors, the ones that help you clot. Factors 1, 2, V7X.
The clot formers.
The clot formers. But here's the key part. It absolutely does not measure the deficit of the liver-derived anticoagulant factors, like that protein C we just discussed.
So it only sees one side of the coin.
Exactly. So you can have this prolonged INR, this high number.
Which looks like a high bleeding risk.
Suggesting a high bleeding risk. But actually, because those natural anticoagulants are also low, the patient could, in fact, still be at significant risk of clotting.
Because that prothrombotic imbalance is still there.
Precisely. It paints a really incomplete and potentially dangerous picture. And the studies are very clear on this. Things like platelet count, the severity of the liver disease itself, PTT and INR, they are explicitly stated as not reliable predictors of VTE risk in cirrhosis.
Not reliable predictors. Okay. So what does this all mean for a common anticoagulant like warfarin, which, relies so heavily on INR monitoring?
Well, the limitations of INR directly hammer warfarin use in these patients. For starters, the INR targets we typically aim for with warfarin, they just haven't been validated in patients with cirrhosis. We don't know if 2 to 3 is the right range.
So we're flying blind, basically.
Pretty much. And to make things even more complicated, many cirrhotic patients already have a baseline INR that's in or even above that typical therapeutic range of 2 to 3 just from their liver disease.
Right. So how can you even tell if the warfarin is working or how much to give?
You really can't. It effectively eliminates warfarin as a reasonable alternative because you can't accurately assess its effect or safely titrate it. It's like trying to, navigate without a working compass.
Okay, that makes warfarin sound pretty much unusable here.
Right.
Are there other monitoring challenges we should be aware of beyond just the INR?
Yes, definitely. Monitoring things like APTT or anti-anxiety levels, which we use for heparins and some of the newer drugs, the DOACs, that's also generally not recommended.
Right.
It's because cirrhotic patients often have reduced levels of antithrombin III. That's a crucial cofactor that heparin needs to work properly. So if antithrombin III is low, the results of those tests, the APTT and anti-ZACA, can be affected, making them unreliable for monitoring efficacy or safety.
Another layer of complexity. So if warfarin and traditional monitoring are problematic, what are the reliable options? What can we use for patients with cirrhosis who genuinely need anticoagulation for things like DVT or portal vein thrombosis or atrial fibrillation?
Yeah, that's the crucial question. The guidelines from leading experts provide pretty clear guidance here. Low molecular weight heparin, or LMWH, is generally considered the treatment of choice for prophylactic or therapeutic anticoagulation in cirrhosis.
Why LMWH specifically?
Mostly because there's a well-established body of safety and efficacy data in the specific patient population. We kind of know how it behaves. Unfractionated heparin, or UFH, the older type, is a reasonable alternative, especially for patients who also have kidney dysfunction. But, as we mentioned, that APTT monitoring can be tricky.
Right. Okay, so heparin options are preferred. But what about the newer direct oral anticoagulants, the DOACs? They've been such a game changer elsewhere. Are they finally proving safe and effective in cirrhosis?
So the DOACs show promising evidence, though I have to stress it's still somewhat limited compared to other conditions. There's a recent meta-analysis, actually, specifically looking at patients with portal vein thrombosis, a clot in the vein leading to the liver. And it concluded that DOACs were more effective than both warfarin and LMWH in achieving complete recanalization, basically, clearing the clot.
More effective. That's significant. What about bleeding risk? That's always the concern.
Well, and this is the important part. This effectiveness was associated with similar rates of bleeding compared to warfarin and LMWH.
Wow. More effective, similar bleeding. That sounds, almost too good to be true. Are there caveats, any ongoing debates about using DOACs here?
That's a great question, and yes, absolutely. It's definitely not a blanket recommendation for all DOACs. Big caveat there. How these drugs are processed by the body, their pharmacokinetics are absolutely key here. It really comes down to the individual drug's journey through the system, especially the liver.
Makes sense.
So, for instance, apixaban, edoxaban, and rivaroxaban, they undergo significant metabolism through the liver's CYP enzyme system.
Right. How the liver processes meds.
Exactly. And they have considerable hepatic elimination, meaning the liver is heavily involved in clearing them out. Because of this, manufacturers generally recommend against their use in moderate to severe cirrhosis. We're talking Child-Pugh Class B or C patients, indicating more severe liver damage.
Okay, so those three are generally off the table for more advanced cirrhosis.
Generally, yes, according to current recommendations. Dabigatran, however, kind of stands out.
How is it different?
It undergoes no CYP metabolism, and only about 20% of it is eliminated via the liver.
Oh, interesting. So much less liver involvement.
Much less. This suggests its kinetics, how it behaves in the body, might be more similar in cirrhotic patients to people without liver disease. That's a potential big advantage. The manufacturer of dabigatran doesn't recommend dose adjustments or specific caution just for moderate hepatic impairment.
And it has a reversal agent available.
Yes, that's another point. It's currently the only DOAC with an approved reversal agent readily available in many places, like Canada, for example, which can be an important safety factor for some.
Okay, so for you, the listener, understanding which specific DOAC might be considered is crucial. It really depends on the severity of the liver disease and the specific drug. Definitely not a one-size-fits-all situation.
Right. Okay, let's shift gears slightly. Finally, what about surgical patients? How do all these anticoagulation complexities play out when someone with cirrhosis needs an operation? That seems like a high-stakes scenario. It absolutely is, and assessing true bleed risk perioperatively remains quite challenging. Again, that INR. It's not a valid predictor of bleed risk in these patients, even if surgical teams might instinctively get worried by a prolonged baseline INR.
So surgeons might see a high INR and want to correct it before surgery.
Exactly. It's like, checking the oil pressure when you really need to check the tire pressure before a race. It's looking at the wrong thing. The American College of Gastroenterology actually advises against giving prophylactic fresh frozen plasma, FFP, just to lower the INR before procedures.
Because it doesn't actually help.
Studies haven't reliably shown it decreases the actual bleed risk during surgery, so you're giving a blood product without clear benefit. The good news, perhaps, is that the general recommendations for managing anticoagulation around surgery, things like when to stop the drug, whether bridging therapy is needed, are generally no different for cirrhosis patients compared to those without liver disease.
So the timing and bridging rules are basically the same.
Broadly speaking, yes, though clinical judgment is always key.
Okay. Wow. We've certainly peeled back a lot of layers on anticoagulation and cirrhosis today. We've revealed this delicate hemostatic balance that many are still surprised to learn about. We've seen the striking unreliability of the INR, a test so many rely on, and looked at the targeted use of safer alternatives like LMWH and potentially specific DOACs like dabigatran. You've really seen how crucial it is to move beyond conventional thinking in this complex area of medicine. So what does this all mean for you? Maybe consider how this deep dive into just one aspect of liver disease challenges the whole idea of simple cause and effect in complex biological systems. If the liver, just a single organ, can create such a nuanced, rebalanced system of bleeding and clotting risks that completely defies our initial assumptions, well, what other rebalanced systems might be at play in the human body that we're only just beginning to understand? Something to ponder until our next deep dive.